I'm Adelina Comas-Herrera. I work at the Care Policy and Evaluation Center. I'm the director of the Global Observatory of Long-Term Care and the principal investigator of a project called Strengthening Responses to Dementia in England that we call Stride England. So Stride England comes from ideas that came up when we were doing another project also called Stride, again, Strengthening Responses to Dementia, in 7 middle-income countries. And in that project, we were looking at how different countries that are aging very fast could respond to the challenges posed by dementia. And some of the questions that came up there made us then think a little bit about how to bring some of those research questions to England. And in particular, we were really struck by inequalities, by how different people's experiences were in experiencing dementia, care and support, depending on where they live, depending on their educational situation, depending on their ethnicity and all sorts of characteristics. And we are aware that there are differences in England too, so we borrowed some of the things that we learned in Stride, that, for example, the understanding of different localities, different mixes of people who might be living in the same place but have very different experiences of in theory, the same services. And we have only started to think about inequalities in experiences of dementia quite recently, but we have been aware for a while of what we call geographical inequalities. For example, the rates of a diagnosis of dementia, which is something that is measured in England, are very different in different localities. So there is some data that shows that. And when you have data, then you can, of course, then start to say, yeah, there are differences here. And then there's been some work to try and understand those differences. So we know that people from different ethnic groups have different cultural understandings of dementia, but also of care. So they might have very different views of whether you should seek a diagnosis and when. There's also differences on understanding whether dementia is what they call a natural part of aging, or whether it's actually a disease. And of course, we know scientifically that it is a disease, but quite often people will attribute this just to old age and something that one should accept. And they will not be seeking support because of that. So it's really important to understand that when we look at data on differences on diagnostic rates, because one thing might be that the services are not available or are not there, or the other may be that people don't want to go and access these services, and we need to understand the motivations behind that and the barriers that people experience. So Stride is trying to understand what are the individual, the local, and the national dimensions that are affecting inequalities. So there may be some issues that are really to do with the individual level, and we see, for example, big differences on how people navigate the access to care. So we find some people that are really quite demanding, and they have high expectations of what our care, health and care, social care systems should be offering them. And then we find other people who feel that they shouldn't cause too much trouble, and they don't really seem to engage, and they don't even ask for services that they would be entitled to. So we find these individual level variations. There may be some variations which might be linked to, as I said, to culture. They might be linked to a socioeconomic status. It might be linked to sexuality. It might be linked to religious considerations as well. And then we have, of course, the locality, and it's not the same to have dementia if you live in one of our sites, which is in Southwark in London, or if you live in Northumberland and you're in the middle of a very rural area, and the type of things that are available to you are completely different. And the other dimension, of course, then is what are the national policies and how do they support people with different characteristics, again, in being able to engage with services. So, for example, in England, many people are outside the public social care system, so they have to fund the care themselves, and they're not really supported in accessing care and support. The way the Stride England project is structured, what we're doing is we're looking at the individual characteristics and situations in which people find themselves, And then we are looking at how this is affecting their experiences of their local services. And then we are looking at how the national policies are again affecting both what the local services can offer, but also directly impacting individuals. So an example of that would be the entitlement to benefits, the access to social care. This is all depending on people's characteristics. And not everyone has the tools to navigate. And in some areas, they will have more support to navigate these rather complicated systems we have. In others, people will have less. We're finding also that, as well as the kind of characteristics that you can list and group, for example, ethnicity, age, type of dementia, your sexual orientation, your ethnicity, of course, your culture, your migration status. So as well as all of these characteristics, and of course socioeconomic status, we find that there are other personal characteristics that are really important. Like, for example, that some people are really good self-advocates and they're really good at navigating the system and getting everything out of the system, whereas other people seem to believe that they shouldn't make a fuss, and that this type of personal attitudes are also really important in the type of access to care people have. In Stride, we have always believed that we can learn a lot from people with lived experience. So we have an advisory group of people with dementia, an advisory group of carers. We speak to them separately, although we do think of bringing them together towards the end of the project. And they have done two things. One of them is to give us some broad guidance at the beginning of the project on what are the main issues that they think can lead to inequalities in accessing care and support, and also dementia treatment and diagnosis. And they also are helping us analyze the data. So we are sampling for diversity, and we are finding diversity for sure. And that's been really quite fascinating. I think perhaps, and this is of course not new to our project, but it's really quite sobering how for some of the people dementia is really just one more complication in their life. So we've got people with serious health conditions who live on their own and who are really struggling to access help for their other health conditions because dementia doesn't help them with knowing how to access appointments and working out how to get to their different medical appointments for their other chronic conditions. So they're really struggling with managing other illnesses. And I think we should be really conscious that we often talk about dementia and as being a thing on its own, but for the people who are they're experiencing this alongside many other life challenges. When we think about dementia, we have to be very aware of two things. First of all, that the risk of dementia is not equally distributed. So people who are more disadvantaged, we find have a higher risk of developing dementia, and the evidence on this is growing. And so that means they're already not your average population, and maybe their resources to respond to dementia are not the same as they would be for the general population. And then we need to think about how our care systems may be exacerbating these inequalities when people do go on to develop dementia. I think being aware of that and being aware of what we can do to actually reduce these inequalities would be a really important thing to consider in Dementia Action Week.